All right, I think we'll get started. So for those of you that have recently joined, if you could please type in your name, your position, credentials, and facility affiliation, we greatly appreciate it. We do have to track all of this information for grant purposes, so I do have to report this. We'll keep this webinar series going, so I do appreciate those of you that take the time to do that. So welcome, as usual. If you're not from Montana, I do ask that you also include the state that you are from. And if you can, please do turn your webinar on. We like these to be very interactive sessions instead of, you just staring at the couple of our faces. We'd like to see you too. So if you're comfortable with turning on a webcam, or if you have a webcam, we greatly appreciate that. Next slide, Jenner. All right, so our agenda today, we do have a special speaker today. We have Jeff with St. Vincent's here today to kind of do a case presentation for us all. So really excited for that. So thank you, Jeff, for joining us. And next slide. And I just want to remind everybody that we host these monthly webinars on the first Wednesday of every month. So we are going to continue these through the new year as well. So our next session will be on December 1st, and then we actually will have a session in January as well. So please keep an eye out for any emails that I send. I did send this morning to the Montana APIC listserv. I've also included our Montana Hospital Association contacts, as well as individuals that have reached out to me directly and asked to be on this listserv. So if you do know somebody that would like to be added to this email list for anything related to our Montana Antimicrobial Stewardship Coalition, just let me know and I can make sure they get added to the distribution list. All right, I will hand it over to Vince. Did you have anything for housekeeping that you wanted to mention?
Welcome, everybody. Hello again. We are really glad that you guys are participating in this, and we encourage as much participation as you can afford. We really enjoy getting the feedback as well. So if you have feedback for us, please provide that. In as much as, is it helpful? Is it not helpful? What would be helpful? What topics or discussion elements would you like to hear about? And then we can go about that and try to secure some of that. We'll provide obviously some structure and so on and so forth, but everyone out here is kind of on the front lines, and so that's what we need to hear from, and that's what we like to hear from. What topic is going to be helpful to you in that sense. So those are just a couple of the things that I'd like to underscore a little bit. Other than that, we can, I asked Dr. Jansen to provide a topic today. So, and I let him choose, but he's got some really interesting pieces and bullet points that he wants to really kind of emphasize. So while the meat of the topic may not necessarily affect you, I think his underlying theme is really important. So pay attention to that. And then I'm going to, without shifting it back to Erica, if that's okay, probably just pass it on to Dr. Koo, who will give us some tidbits on another vastly important topic. Dr. Koo.
All right, thank you very much. And again, I would like to echo what Vince just said about feedback. It's really, really important just to just give us a couple of sentences or so, just to let us know how what we're presenting, is it useful to you? Is it the way we're doing it? Is it helpful or not? If there are other topics or specifics, I know a lot. We are doing very, very basic things right now, just because we have such varying level of understanding and about antibiotic stewardship. So we decided to kind of start from scratch. But so please bear with us if there's a little bit like we're talking about things that you already know. But but our hope is that we can have a little bit of more basic stuff and a little bit more advanced topics for each session so that it will be useful for everyone. So I am going to, let me see if I can share the slides here. I am, all right. So can everyone see my slides? Okay. Is that a yes?
Yep, you're good.
Oh, okay.
Yes.
All right. So last time when we talked, we briefly went over the, I went over the how to assemble your antibiotic stewardship team. Kind of discussed what the core personnel will need, as well as what extra other folks in the organization could help with your antibiotic stewardship program. Once you have assembled your team, then the next step is really to kind of to discuss about what you're going to do next. For most of us, we're from most facilities are required to have an antibiotic stewardship program. But the question is what do you do with it? And there is also that expectation of you have to show some outcome of whatever you're doing. So, and I think that's where a lot of questions I get sometimes when people are trying to figure out, antibiotic stewards are trying to figure out what should I do, what should I focus on. Now, the first thing I kind of want to start off with is there's no cookie cutter method of doing this. So, even though the big pictures may be really the same for everyone, how you get there may be different from everyone else, and that will depend on you have to tailor a program to your organization. So that's where things are maybe a little bit different, but also we can, if it works for one place, it may work for others. And so this is kind of one of the reasons I want this session to be more interactive is, what worked for other people, because many of these ideas that if you get to read about, it's really have come from like large academic organizations, and many, and even the Billings Clinic, we don't have the luxury of a lot of those resources that they have. So that's actually one of the why it's so important for us to share ideas, is because we can't do whatever like Mayo Clinic does or University of New Mexico, anywhere. So to start, really, as I kind of pointed out, there is that the reason we're doing it for antibiotic stewardship and why now it's becoming a requirement is because of these big pictures, the ideas. When antibiotic stewardship was initially, the idea was conceived, the driving force behind that was because antibiotics were one of the took the largest chunk in the budget for a pharmacy, and that contributed to a huge component of the annual pharmaceutical costs of an organization. So the goal was really to try to get, try to decrease the amount of indiscriminate antibiotic use. And that, this is back when Big Pharma was really advertising and really kind of, trying to nudge physicians into using their new products. And I remember when I was starting out as an ID doc, when ertapenem was a big thing, every surgeon loved it, and they used it for their pre-surgical prophylaxis. Because it was easy to use. It was a one-time dose. It lasts 24 hours. And there's not a whole lot you need to do. It's really mindless of it, and so it was very commonly used. But then, because it was so expensive, it showed up on, as at the end of the annual reports of how much, what antibiotics, the cost of these antibiotics, and it became substantial. So this initially started as that, but then it has antibiotic stewardship has now evolved into other areas which is what the CDC and CMS are all kind of focusing on. That is, reducing antimicrobial resistance, reducing complications using antibiotic use, as well as improving patient outcomes, patient care outcomes. So now there's a little bit more of a different dimension. Instead of focusing on trying to reduce the amount of antibiotics being used, now we're looking at all these different other domains that's being, and we're and the outcome, and certainly depending on which agency that you use to do your accreditation and such, we'll look at all these different components. So one of the earliest guidelines in regards to antibiotic stewardship really kind of focus on a few things, recommendations, and how to build what an antibiotic stewardship program should include. So the two big things were the prospective audit with intervention and feedback, which most of us are still using, as well as formulary restrictions, and the requirement for any authorization for using restricted antibiotics. And they have had some really good, those are the two big things that still in use, and they're fairly effective. Now, it's easy for me to say, and certainly for IDSA and SHAE to say this, but how to implement this is the big challenge. So, and that's kind of where I'm going to describe a little bit later on. Other things that were kind of that's been recommended, including education, providing practice guidelines and clinical pathways, having the requirement. This is back in the days before, kind of as EMRs are starting to come out, but there was still a fair bit of handwritten or at least typed in order forms, is that there's a requirement to fill out a form. If you want an antibiotic, a specific antibiotic, you have to get this antibiotic order forms filled out, and that will be reviewed to see if they're being approved or not. Combination therapy was recommended back then. This is back early on. This is kind of gone away since then, but this was really kind of address some of the concerns about resistant organisms, particularly certain gram negatives. So, but that was included. Streamlining and de-escalation, still very, very applicable nowadays, to try to get people either get down to the de-escalate to the most simplest antibiotics that will still be effective once pathogens and identified. Dose optimization, very important, especially in those who are much larger than the average patient, or who have renal or liver issues, and then the IV to oral conversion, to kind of try to get them transition out of that, instead of keeping someone on IV antibiotics throughout for the length of their hospitalization, is to try to get them over to oral. Again, usually that is part of the de-escalation of therapy process. Now, just kind of how does this apply? All these little principles apply to this. And so I decided to kind of use this reducing the incidence of C. diff infection as an example of how the different components will fit into how this would apply. Now, many of us are being asked to do this, and this is actually one of the metrics that NHSN looks at as well. And there's a lot of ties with infection preventions and patient outcome scores and whatnot. And as probably all of you know, there is no one fix for this. That you can't, and even though your C-suite or may think it's like, oh, you could just kind of do this and now take care of the problem. But this is it requires a multidisciplinary approach. So there are two main domains that I kind of broken this down into. And the first is what we most commonly are familiar with, which is the antibiotic use portion. And that can be then, certainly that big, and this is to address the most, the most significant and addressable risk factors for developing C. difficile infections, and that is using antibiotics. Certainly not you don't hear that many that often where someone developed C. diff without having been exposed to antibiotics recently. So this is to address the risk factors. And if you look, and then you can also further break that down, because it's not just antibiotic use, and many patients will need to be on antibiotics if they develop a medical condition or an infection. So it's just to say not to use antibiotics is not going to. You should not use antibiotics is a reasonable solution. So you have to look into these different domains. And so again, I've broken it down to what will trigger antibiotic use, how do we use the antibiotics, and when do we stop the antibiotics? And all those three factors do play a role into the stewardship, which affects the incidence of C. difficile infections, which most of us are very familiar with. A newer area that has kind of evolved, and Shay is working on having some position papers on this, is the concept of diagnostic stewardship. And this is mostly focusing on, again, more on how antibiotics are being used, what triggers the use of antibiotics. And because we're now recognizing, and probably all of you know, is that, that there are certain triggers for that clinicians would use, would kind of a knee-jerk reflex to use antibiotics. Probably the most common example is the UA, the abnormal UA. And this is a very common problem every facility deals with, and also contributed to a lot of the issues we kind of talk about: C. difficile infection, antimicrobial resistance rate. So certainly, so now we're really kind of, this is evolving into a big, into another realm of antibiotic stewardship to help address some of the issues, the big picture issues we talked about. And that is kind of broken down into two domains. One is what will trigger, when should we test someone? Because it's not so because of the result of the test is what will result in starting the antibiotic. So you certainly want to see how we can modify behaviors so that will determine when a clinician should to test the patient for a specific condition. The other is that, and this is relatively new, is how to select antibiotics. And this is now that we have all these multiplex PCR-based tests, MALDI-TOF and such, that we, instead of the need to do empiric antibiotics, we can identify a pathogen in much shorter period of time and select the most appropriate antibiotics instead of waiting for a pathogen to be isolated on a culture and then have to go through that whole process, which takes at least a couple of days. So, and that will help. That will also help with doing the optimization of antibiotic choices, as well as as well as duration. So just to kind of looking at these different domains as I come out. So if you look at the antibiotic use, there's, I've kind of broken down into all these different areas. So again, what will start it, what would trigger appropriate antibiotic use? So making the right diagnosis, coming up with a good clinical pathways or an empiric antibiotic selections. We do need to include some restrictions because you can't just use meropenem on every patient. So certainly that should kind of play a role in that. Making sure that specimens are properly collected. One of the banes of being an ID physician is that ER doc who just start antibiotics and then collects a swab and nothing grows out of that swab or whatever. Or the surgeon drained a pus and all they did was dip the tip of a Q-tip and sent that for culture, and then you don't grow anything. So these are the kind of areas that we kind of certainly to kind of help guide how antibiotics should be started. Then look at optimization. That's, as I've mentioned, about weight and renal function based, but also what the disease is. You're not going to use the same antibiotics to treat, for example, ceftriaxone to treat a strep pneumonia using the same dose that you would treat a strep pneumomeningitis. So certainly, making sure that they're appropriately dosed for the right disease is also important, so that you have better outcome. As culture-based adjustments, very, very important. If you grow out a gram-negative organism and you're treating and you have them on vancomycin, obviously that's not going to work. So certainly having to make sure that these adjustments are made appropriately based on what data we have. And then finally, trying to de-escalate the regimen. Converting from IV to oral is always a good thing, just so that not only is not so much as reduce resistance, so to speak, or other things, but to shorten the length of stay of patients, things like that. Other things, antibiotic termination, helping establish some treatment duration or an endpoint, because again, there are a number of diseases that, depending on the situation, will have to determine how long a patient needs to be on antibiotics. Then Education and feedback. These are things that you could do. These are easy things to do. They're not as well, the education part, even though it's essential, it's not probably one of the least effective ones, but I think it's important to have that included as part of the program. And then prospective audit and feedback. This is something that is what most ID pharmacists are very familiar with, because if we do this, they do this quite often, and they're usually real time. They get a culture results, and usually it requires a phone call to the provider, say, hey, Mr. Jones had this grow at the blood cultures. Maybe you would consider changing the antibiotics to this, so whatnot. And so those are usually can be helpful, but again, depends on how you do it. That may be a little challenging, because depending on what are your clinicians are, whether they're more receptive to these feedback, or they're like, look, I'm the doctor, I get to decide what I want to do, click. And that has happened before. So a couple of other things, like antibiotic use report card has been looked at. This is more for outpatient antibiotic stewardship, and this usually give a picture of antibiotic use for each provider over a period of time. And they're usually give them a really good sense of like, oh, you tend to use Augmentin for everything. And the hope is that we can break it, that they can break it down into disease process and see, well, do you really need to use Augmentin for for a simple cellulitis, things like that. And so hopefully with that feedback, that they can clinicians can understand what they do, and maybe hopefully do some modifications. As for diagnostic use, again, defining a testing criteria is very important. So, and again, I'm going back to the example of reducing C. diff infections. Looking when do you test for C. diff? That's very important. That's probably like 50% of the problems, at least depending on which facility you're at. But also when to test for other infectious processes. And one of the challenges for ID is that our tests are not, some are really good, others are not terribly great, and many clinicians don't really differentiate how tests should be interpreted, or if they choose to interpret it. So when they and that causes, a lot of times that triggers, because of a lack of that understanding, triggers a use of broad spectrum antibiotics. I see that all the time here at Billings Clinic. And it's a tough challenge, because for a variety of reasons. I mean, mostly it's because of fear, that they're afraid that they're missing some diagnosis. And and they use a very non-specific test, an insensitive non-specific test, to try to give them justification for using broad spectrum antibiotics. Happens all the time. So again, something to look at, to how to, that you could use to tailor to address that issue at your facility would be helpful. And then which test order? I'm kind of using that for both C. diff and infectious process, but again, for C. diff infections, we know that there's no perfect C. diff test, right? That if you're using the GDH, glutamine dehydrogenase, or the toxin assay, is they're less sensitive but more specific. But on the other hand, the PCR is too sensitive and not specific for active disease. So again, which test you choose will have to determine what you're going to do, what you're going to end up doing. So there's that component. Other things about now that we have newer technology, antibiotics, it does help with antibiotic selections. Rapid ID of diseases is becoming a bigger, becoming more available. We now have PCR-based tests. I mean, all of you have heard of BioFire, Cepheid. Now there's other ones called Accelerate. And then the other technology that's not PCR-based, such as the T2 MRI. That's a really cool one that doesn't even require that you can use a blood specimen and put it into that machine, and it will actually detect detect some of the pathogens. So you don't have to wait for a culture like what PCR does. And then MultiTOF, which is again, it's not a new technology, but it's new to medical technology on what we can use to identify pathogens. They all have pluses and minuses. Mostly is that they're pretty expensive, but the payoff is that you get the diagnoses quicker, and you can kind of de-escalate and turn that less likely to need to use extended periods of broad spectrum antibiotics. Other things you can consider is that the MECA gene detection, that's a lot of the PCR tests like Cepheid and BioFire had included. And then the ESBL and the carbapinamase resistant bacteriacease, that is also, there are tests that you can do, again, PCR based tests, so that you are now placing, can determine if a patient needs to be on vancomycin or other antibiotics, depending on the detection of those genes producing those resistance. So just to kind of give you an example of what we do here at Billings Clinic, and I'm going to go through this. I know I'm kind of running out of time, or ran out of time, but is that these are some of the things under those domains I kind of describe what we are doing in Billings Clinic. So for antibiotics, we have what we call power plans, and they're for certain specific diagnoses. So community-acquired pneumonias, we have set, and that's very common, community-acquired pneumonia, UTIs, cellulitis. They're most organizations have that, and there's like, these are the recommended antibiotics. This is what you do, and you should, go from there. Others are, we do restrict our fluoroquinolones to only allow certain fluoroquinolones to use in certain conditions. So having a restricted antibiotic list. We also kind of, most facilities do this, collect a blood culture contamination rate. And this is, again, depending, this is a good way to kind of determine, because how often a blood contaminant is being detected, which is usually reflective of how well the specimens are collected. And as I mentioned to you before, most clinicians don't try to sit there and differentiate readily whether a positive blood culture with gram-positive cocci is that contaminant or not. And so, so facilities that have a higher contamination rate tends to have a higher vancomycin use, because so certainly having that information hopefully will improve techniques and practices by their phlebotomists. Other things that we do is antibiotic optimizations. Our ID pharmacists do debug drug matching, as well as adjusting doses and make sure they're on the right antibiotics for the right disease process. Our termination, just to recommend, we do have a digital reference guide. It's called First Line now. It used to be called Spectrum. We kind of listed for our clinicians for recommended general durations of treatment for a variety of things like pneumonia, cellulitis, UTI, and whatnot. But we also have included that's been kind of used at other facilities called handshake stewardship, where we have our ID pharmacists and one of the ID docs to sit down and actually kind of review, reach out to the make themselves available and reach out to the providers to kind of talk about their specific cases and offer guidance. Ideally, the way we do it is a lot different than what's been described at down in the Children's Hospital in Colorado. They're actually actively going to different floors and actually meeting the clinicians. Ours, we're just kind of waiting to kind of for them to come to us. So it's not as effective as I like it to be, and that it's really more of a let's catch those docs to kind of suggest that they need an ID consult rather than offering a more guidance on antibiotic use. But it does kind of, but again, not finding those patients who should have, who need an ID consult is just important for antibiotic stewardship, as what we just described. So. And then the last educations, we do talk about all these, offer grand rounds and didactic lectures. As I mentioned, this is not the most effective, but also have some, but can offer at least some, we get through to some of the providers. But our prospective audit and feedback is probably the brunt of our antibiotic stewardship program, where our pharmacists will review the list of patients on antibiotics and determining if they're matching their antibiotic matches the right bug, as well as the diagnoses. They do, she does, this is JC Ott, who reaches out to our other providers to offer some recommendations. And if there are concerns, bring it to their attention. We do have we also have a medication safety officer who also reviews for medication errors as well as safety issues. So, and then, so as for the diagnostic stewardship, we're working on trying to do some efforts to limit inappropriate ordering in cultures, such as the pan culture that's really common around here. Making sure that cultures are appropriately ordered and they're appropriately collected. Again, I'm still struggling with our surgeons who like to drain abscesses, but I don't know why they can't just send all the pus to the lab instead of just dipping that tip of a Q-tip into the and then send it off. But and half the time it doesn't grow anything. So hopefully, so try to set up a system to ensure that that's done appropriately. And then this is just an example of what we do here for C. diff testing, making sure that if a patient is being suspected of having a C. diff, that these criteria are met, that they're not on stool softeners, they're not on tube feeds, that they're only being sent for a liquid stools. And so that and as all of you know, that the tests that we have do not differentiate between true disease or a colonization, or so we do need to make sure that if we're going to get deemed for a case of C. diff, that it is correctly, appropriately diagnosed. And lastly, is that the antibiotic selections. We do have a biofilm, the biofilm where we can look at the MEK8 genes to make sure that there's a patient who identified to have Staph aureus in their blood. Does it need to be on vancomycin? Can we switch to cefazolin? And then the respiratory panel. Does this patient have flu or pneumonia? Again, two different varied treatments, but certainly if they have the flu, probably don't need the antibiotics. So. Some of the, and then this is my last slides, but just want to kind of point out, it sounds grand, but there are challenges, right? Probably the biggest one is a physician acceptance. And this is where how you have to play with how much at the point where you can determine what you can do what are some of the things that it's easy that you can nudge a physician to do versus what are some of the things that, look, you're going to have to set up a hard stop to do. And so an example is we can certainly ask our physicians if a blood culture is negative after 48 hours, they should stop it. How often that happens? Not that often, versus maybe we need to do something a little bit more stricter. And so trying to find that sweet spot may be a little bit challenging to make sure that what you implement is well accepted, but you're not going to create such a fuss by the staff that then they're going to dismantle it. So that's probably one of the biggest challenge most of us experience. Others, for us, particularly IT support, depending on how much support you have, this plays an important role. As I mentioned last time, why they were have to be part of the antibiotic stewardship team. Having nursing support, very important, because even though we kind of not think of antibiotic stewardship as part of what a nursing activity, but they can be a very integral part and supportive part of that. And then finally, having the C-suite support. Now, fortunate for most of us is that our C-suites recognize that they need to support an antibiotic stewardship program because of Joint Commission or DMV, and to be able to get participate as a condition of participation for CMS. So you'll get their support. How much of that's is something that you have to work on. Everyone is work on, is because to be able to get all how much IT support you're going to get or how much nursing support you get will require how much support you get from the C-suite. And then finally, yes, it sounds great if you have these people to help you out, but if you don't, that's also another challenge. So, and we are really strapped on our IT technicians. So that's been one of our biggest challenges. But being an antibiotic steward is not so much as just following a cookbook method, but it's also trying to be a problem solver and trying to think of different ideas to make what you have available work. So, and that's all I have. One of the really good resources and I didn't mention previously, is to check out the SHEA website. So this is Society of Healthcare Epidemiology of America. It's I'm actually a member of them, and so they have a lot of practice guidelines, as well as some free educational sessions, particularly in focusing on antibiotic stewardship that's available. So certainly check it out. You know, and I know that they also do a few podcasts as well as some YouTube videos. So I will try to send those also the links to those to you in future sessions. And that's all I have.
Great, as usual, Dr. Koo, thank you very much. I would suggest that in the interest of time, let's, any questions that you might have, you can either put on the chat line or we'll wait until after Dr. Jansen presents, and then we'll see what we have. Jeff, are you ready to go?
Yep, I am. So I will, can you hear me?
Yep.
Yes.
Perfect. I'll go ahead and share my screen. I'm going to go ahead and repeat. I don't know if more people joined, but I will repeat that if you are new, post your name, position, credentials. I'm reading this from Jenner's thing because I don't remember exactly what it said. And state into the chat box. Let me know if you guys can see my slides. And then I would like to thank Vince, Neil, Jenner, and Erica for letting me give this presentation today. It's going to be a patient case, and then I don't care about awkward silence. And so if people want to unmute themselves when I ask a question, I would appreciate it, because otherwise we'll sit here twiddling our thumbs until I advance the slide. Some other things, I think this is the first time I saw this stewardship schedule, and I just want to say I think that this is an awesome schedule, and again congratulate Vince and Erica and Neil, I think, and Jenner. I think that the schedule looks like a very inclusive and well-rounded topic discussions about a lot of the things that make stewardship important, especially focusing on diagnostic and laboratory stewardship, which is kind of some of the newer stuff coming out, and Neil alluded to that in his talk. If you have any questions, please feel free to put them in the chat. And then it looks like we mostly have nurses and a couple pharmacists. And so can you see my slide, Vince?
Jeff, we can see your screen, but not your slides.
Okay. Let me try to redo this. New share. Oh, there. Good. Okay. So with that, we'll go ahead and start the case. I also apologize, I don't have a webcam, so you can't see my face. But so this is a case of appropriate antibiotics for chest pain. This is a real patient case, and all identifiable data has been removed. Okay, so this patient is a 27-year-old white male. He presented with a chief complaint of left upper chest pain with worsening shortness of breath. Did not complain of any palpitations, but did complain of a cough for 1 month. His past medical history involves asthma and depression. He was treated by his primary care provider with a Z-Pak for possible bronchitis 2 weeks ago, had minimal improvement, and he lives here in town in Billings with his fiance. He works for a local construction company. So every person in RER gets a chest x-ray, and so this is his chest x-ray. His CMP was largely unremarkable, other than his serum creatinine was mildly elevated and his albumin was slightly low. His procalcitonin was very high at 36.51, and then his CBC was unremarkable except for his leukocytosis, which was largely neutrophilic. You can see his chest x-ray. He has this large infiltrate as well as a pleural effusion. And so because of that, we did get a CTA. I'm not sure why they did the angio, but it was negative for a PE. And there was this large loculated left pleural effusion and empyema. And then he has this known congenital right lower lobe lesion. Since we have a image of it, we might as well say what it is. So for some people looking, we can tell that this is loculated because it does not coalesce onto the bottom with gravity, but we've got multiple, this all communicates, I could only fit 3 images, but multiple areas where it does communicate with this empyema throughout the lung. So the base is basically full. As it comes up, it does go into the upper lobe, and then this is the upper limit of the upper lobe. So this patient is from the community. He's young. He lives in Billings, Montana. So the first question, and he comes in with a community empyema, essentially. So the first question is, what is the most likely pathogen in this setting? And all of these questions, I ask for reasons because I think reaching back to stewardship, as pharmacists, as nurses, as providers, everyone can kind of play a role in giving the patient the best care possible. Oftentimes it's not uncommon for us to have surgical patients transferred to us, like in this case where they're transferred on Mirum, or they're transferred on something else. So what are the most likely pathogens in this setting? I will wait. No one wants to talk. You can type it if you want to be shy.
I'm
H,
a
I
pharmacy
like H.
student.
Yeah, go ahead.
I'm a pharmacy
just-
student. I was thinking anaerobes would be a big one.
Good. Yeah, I think so. Anaerobes absolutely are a big one in a community empyema, and I want to give props to the pharmacy student for being the one to speak. So congratulations. So really the answer is G, but we worry about oral flora or microaerophilic strep, and then anaerobes most likely in this community setting. So you are the ER pharmacist or IED pharmacist or whatever, and what empiric antimicrobial therapy do you recommend? And I say that there is a right answer for this.
Jeff, you can call out the pharmacy students again.
I was just going to say, does the student want to say?
There are two of them here.
Oh, okay. So yeah, well, okay, I'll give you the answer for this one. So vancomycin, absolutely extremely broad for a community-acquired empyema. Ceftriaxone azithro, that's great for community-acquired pneumonia. Again, the 2019 CAP guidelines do say that you need anaerobic therapy for two settings and two settings only, empyemas and lung abscesses. So that is not a right answer for specifically this patient because he does have an empyema. Meropenem, no. And Amstelbactam is the correct choice. Again, we're worried about oral flora and anaerobes, and Unison does cover both. So at this time, what is the most important next step for AZ? Observe the response on antibiotics, home consult for bronchoscopy, surgical consult for VATS or thoracotomy because of how big it is, and then ivermectin for COVID prophylaxis. And I put that in there and then realized I probably need to put in red and yellow blatant information because we have seen this here, unfortunately, in patients transferred to us. So do not do that. D is the wrong answer. So it's 1 out of 3. Or let me do this. How about Dr. Koo? What would you do?
Sorry, I'm having a problem unmuting. Oh, if there's an abscess, drain it.
Perfect. So, so I think that we're on the same page. So surgical consult for VATS or thoracotomy, just based off the size of it, antibiotics aren't going to touch that. They will probably make it, hopefully, not make it so it doesn't get worse, but they are not going to treat this. This is a surgical intervention more than an antibiotic intervention. And so hospital day 2, we did consult CT surgery and he underwent thoracotomy. He had 14 cc's of purulent, sorry, that's supposed to say of, not or, purulent / serosanguinous fluid drained, which from an ID perspective, purulent and serosanguinous are not the same thing. And so I didn't quite know what they meant when they wrote that in their note. Blood cultures were no growth to date, and then the OR gram stain was negative. We generally don't have the same problem where they send a single swab. They actually sent 1,200 cc's of pus to the lab. So we had lots of pus to go off of. So the hospitalist then inquires as to if antibiotic therapy should be adjusted to pending cultures, and you should recommend the following. So the options are change the levofloxacin, continue Unison, change the Vancomycin, or add Vanco to Unison. Anyone want to tackle it?
How's the patient doing at this time?
The patient is stable post-op. He, let's see, when I saw him, his biggest complaint was that his chest tubes hurt.
So I'll chime in. So from a clinical standpoint, I think one is what Vince just pointed out is any need to adjust antibiotic therapy will depend on the patient, if there's any change in the patient's status. So certainly if it's worsening, then I would say, okay, you have justification. But this is something that I do see fairly often, that even though there are patients who are stable, there's this inclination to change antibiotic therapy. And right now, all the necessary things have been done. They've collected the send off the pus for culture. Yes, we're still waiting for the culture to isolate a bug and such. And as long as the patient is a clinic, they're stable, they're afebrile, they look like their labs are kind of improving. I wouldn't suggest immediately to the need to change antibiotic therapy. My inclination is just to continue with the Amsulbactam for now, and again, continue making sure that I'm assuming you had a chest tube that's not draining. Keep monitoring for culture results, and then making the adjustments based on the culture results, or there's a deterioration in the clinical status.
So perfect. So continue Amsulbactam. And I really think the key teaching point for this question is in addition, the bacteriology or the microbiology of the disease process doesn't change because they had surgery, and it doesn't change because they had pus/serosanguinous/unknown drainage based off the OR report. So the horses being horses or common being common is the same microbiology in this setting. So the OR cultures came back as Strep constellatus and Prevotella denticola, both of which are would be very common in this setting. Prevotella is an anaerobe, and then Strep constellatus is an intermediate group strep. I've also heard it called an anginosus group strep. Constellatus just doesn't get any love. But these are three streps, so Strep constellatus, Strep intermedius, and Strep anginosus that are pretty mean in the fact that they like to cause pus and abscesses, and they're pretty common to cause empyemas. And so this is not surprising at all, but they're also very susceptible. And so patient is ready to discharge. This is hospital day 5. Chest tubes were removed. His follow-up imaging looked, relatively good compared to what it was when he came in. He's been afebrile essentially since discharge, and so it's time to send him out. And then what antibiotic and duration do you recommend? So we have Augmentin BID for 14 days, levofloxacin for 7 days, IV ertapenem at the infusion center for 28 days, Augmentin XR for 28 days, and then doxycycline for 21 days. So I'm just going to highlight that. So we sent him out on Augmentin XR for 28 days for an empyema, with the caveat that Augmentin is not necessarily wrong for 14 days post-drainage, but if you do shorter courses, you probably need closer follow-up, especially with these organisms. So brief learning points from this. Again, we kind of went over them, but HCAP is no longer real. We'll talk about this in a moment. Immunocompromised does not mean increased risk of resistance. It does mean increased risk of infection, but not increased risk of resistance. Montana has low baseline resistance rates. And then when is anaerobic therapy necessary for pulmonary infections, which we already talked on. So HCAP died in 2016 with the release of the new HAP-VAP guidelines, and then it was confirmed dead in 2019 when the CAP guidelines came out. I made this gravestone for it. Some of you guys may have seen it before because I send it to lots of places. But this is the study that killed HCAP. It came out, it was published in 2014, and if you have a chance to read it, it is an excellent study. Essentially what they found is they looked for all of the risk factors that were under the previous HCAP criteria and looked actually what was predictive of having a resistant organism in these clinical settings. And at the top line, what you can see is that combining all of them together to HCAP was not significantly different than not having HCAP. So HCAP itself was not predictive of having a resistant organism. The things that they did find as being important are what we generally see in our new guidelines, which is IV antibiotic use in the previous 90 days. Specifically IV, when they looked at oral, it didn't necessarily pan out, although there was a trend. And then really the other big two were admission from a nursing home and prior colonization with Pseudomonas. Prior colonization with MRSA was not significant, although it was pretty darn close. So I do have that on the far right as a consider, which is what the yellow means. I do think the other important thing that we have to consider when we look at empiric antibiotic use for all patients in Montana is, and really everywhere, is what is your baseline resistance rate, or what is your geographic antibiogram? What does your microbiology look like? So remember that this study was done in Chicago, Illinois, which is obviously a very non-rural area. And Chicago has multiple publications for multiple resistant organisms in its case series. So we know that the microbiology of Chicago is very different than the microbiology of Billings, Montana, or the first one I saw was Blackfeet, Montana. So wherever we are located. So, you know, keep that in mind. And that's why we change, when I looked at this, we have changed our recommendations locally to consider if they're at a nursing home, but really the thing is prior colonization that we worry about, and then previous antibiotic use, because our baseline resistance rates are relatively low. Again, we can highlight that immunocompromised did not equal risk for resistance. So you have a patient that comes in and they have febrile neutropenia, for example. They are absolutely at increased risk for infection. You give them the anti-pseudomonal beta-lactam, they don't need Mirum, cefepime, Zosyn, those are both fine. Mirum's not necessarily a wrong answer in that setting, but our baseline resistance rates are very low. So increased risk for infection, not increased risk for resistance. So what are our resistance rates? So this is updated based off St. V's antibiogram this year. So I don't know how it's going to compare to Billings Clinic. When I first made this, this was using the state antibiogram, but that was 3 years ago, and COVID has changed things. So when we look, we're still significantly under the US averages. So our MRSA rates are 33%, the US average is 40 to 43%. Our VRE rates, we've had one VRE in the last year and a half. I put it at 1% because that was low, and then I realized I put carbapenems even less. And then US average is about 6% ESBL. We only have 3% ESBL isolates here. US average is about 12% AMP-C expressing. So these are a different class of organisms that have chromosomal beta-lactamases. And ours are at 12% in St. V's. It was at 7% when I did the Montana antibiogram. So ours went from 8% when I did that to 12% in the last year with our COVID patients. The US average is actually up a little bit to 38%. And then carbapenemase producing, we've had one. I think we had the first one in the state. And then I think Billings Clinic immediately followed us like a month later with the second one in the state. And those are the only two last time I talked to the state that we've had statewide. So there's been two, and they've both been in Billings, and they really don't exist. And then the US average is 3%. So what do we do at St. V's? We when do we empirically treat for resistant organisms? And really the answer is, have they had a history of a resistant organism in the past 3 months? And 3 months is kind of our hard stop limit, because that's where our normal microflora changes. And so, you know, your flora is an evolving environment. And after 3 months, there's general turnover. Now, there are a few exceptions to that if there's a reason to have a chronic infection, so a chronic Foley in patients with recurrent ESBL UTIs, or a chronic suprapubic or something like that, a chronic wound, then we might readjust that time frame. But in your 90% of patients, 3 months is kind of that magic number. And then we consider it based on their clinical status. So how are they doing clinically if they come from a nursing home or intravenous antibiotics in the past 90 days. Again, the CAP guidelines, anaerobic therapy is not necessary for aspiration pneumonia. Again, it comes from your aspiration pneumonia almost always comes from your oral cavity. And so with few exceptions. And so where do you actually need anaerobic therapy is for empyemas and lung abscesses, in which case anaerobes are very common. And that was a very quick review of my slides, but I will open it up for any questions. And I see there is oh yeah, so Erica says to remind everyone that Visa Versas, which I hope that we don't have any here, and then CROs are reportable to the state, and we have seen more. She says there's one per year for carbapenems producing CREs, so that's exciting. Maybe ours were the first Metallo. I think that might have been what it was.
Yeah.
We had an IMP and then you guys had a VIM. So.
Yep, we've had some interesting things. We've seen a couple NDM positive CREs as well. So we definitely see about one a year. It'll be interesting to see. I think a lot of states are seeing increases of their carbapenemase producing organisms. So I do expect that we may see, a couple next year. This year we only have one NDM positive CP CRE so far. Now that I say that, I'll probably get another one.
I will follow that up too by saying that I think stewardship is real. Another plug to stewardship with COVID is the CDC NHSN released their healthcare associated infection formal report today, and in that report, but throughout the country, really because of COVID, there was a 35% increase in the standardized infection ratio for ventilator associated events. 24% increase for bloodstream infections, and I don't remember the exact number, but I want to say it was like 15% for MRSA CLABSIs. So our increased antibiotic use, even in just a year, shows us how much of a difference it makes. And unfortunately, that probably sets stewardship programs back 5 years. So.
Yeah, I agree with that. That's a good point. Because I think that there's probably more of a hip shot approach, for individuals coming into the hospital. I don't know if you would agree with that or not, Neil, but I mean, it's just, before some actual data is there, before we can prescribe appropriately, it's just like, get it on board and
that's actually why we're here. Again, kind of talking about that. This is actually one of the challenges with the COVID-19 pandemic and the increased use of antibiotic therapy is we didn't at the beginning had really much data about the co-infection, and then then there's, I think that most of us had who are involved in antibiotic stewardship got their resources redirected to help with the COVID-19 effort, and so got a lot of the programs got slacked off quite a bit, and we suffered the same thing where every patient who got hospitalized with COVID-19 got IV antibiotics for no reason at all, and that's all kind of stem out of physicians' fear. It's really, they have like a few studies that come, one or two case report, and then it cascades into this big fear of the what if. And that's going to be for all of you, and certainly for me, is going to be the biggest challenge is to to try to convince your provider about how to get over that what if scenario, because that is probably one of the biggest driving factors of all the bad behavior you're going to be seeing in your practice.
Yeah.
one of my favorite sayings is that antibiotics are a provider's anxiolytics. So
Yeah. Well, Dr. Jansen, that was a great presentation, and I appreciate you spending the time and putting that together for us and for the group. So I don't know, Erica, we're kind of at the end. If we have any time for questions, or we can save them for next time, or email those in, or how would you prefer we do that?
Yeah, so if people are willing, we could stay just another 5 minutes to answer any immediate burning questions. And then if you have any additional questions, feel free to email those to me directly and I'll get them to the speaker, and we can kind of compile then a list of Q&As and send that out as well to the email listserv. Any burning questions from anyone? Anything that anyone really wants to ask?
We appreciate your feedback, and let us know if something pops up later on. Email either Dr. Koo or Erica or Jenna or myself. The debate thing there, if you want to debate me, that's I guess, okay, just pick a subject and I'll. Are you saying I'm argumentative? Is that what you're saying there, Jeff?
no, I just didn't want them to call me. So
Fair enough.
okay, well, thank you, everyone.
Thank you.
Thank you.
Thanks, y'all. We'll see you next month, December